Namaskaram everyone and welcome on behalf of Indian Academy of Pediatrics, the Telangana State Chapter and the Trained Nurses Association of India, the Telangana State Chapter to this very special nursing learning series, which is a joint initiative of PATS. So this is a joint initiative of PATS and TNAI, Telangana, to cater to those nursing students who are facing the new curriculum of pediatric and neonatal aspects of nursing in the new nursing curriculum. At the outset, I thank Professor Rajeshwari for giving opportunity to PATS to be a part of this mission to share our knowledge. I'll now request our President PATS, Dr. Sunkoj Bhaskar Garu, to please give his inaugural address and also tell you about IAP. I'm sure some of you would not be aware of the remarkable work that our association does, and we're always at the forefront for advocacy of child health. Over to you, Bhaskar, sir.
Yeah, thank you, Dr. RSV. Good afternoon, Madam Professor Rajeshwari, our eminent faculty, Dr. Aparna, Dr. Pranit Reddy, Dr. RSV, and all the other participants. And I welcome you to this first webinar of its kind. And at Pediatric Association of Telangana State, we were very eager to do these promotional professional activities with our colleagues, that is nurses, and PATS has utmost respect and appreciate the nursing profession because, particularly in non-intensive care units, we, being the consultants or the associates or assistants or residents with the patients, we spend little time, but the remaining entire time is being spent by you, the nursing personnel. And the outcome of a child or outcome of a newborn is dependent upon your care, your affection, your compassion, your empathy, which will make a remarkable progress in parent satisfaction, not only in parent satisfaction, even the child's health outcome. And that's the reason myself, Dr. RSV, Dr. N.L. Sridhar, we were actually planning to do these professional activities with our nursing personnel in order to improve their professional competence and skills to provide a better care to our sick newborns and children. It's always, as an academician, it's always, I cherish the idea or cherish the plan of having regular medical education programs to update our knowledge, skills, and competence. When I say our, it includes even nursing staff. We belong to one family that comes under healthcare professional. So in future, we wish we will have these activities regularly. We are here to help you. And fortunately, in Hyderabad, we have eminent faculty for newborns. And luckily, this time, we have one of the top-rated, one of the few best neonatologists, Dr. Aparna and Dr. Pranita Reddy, are with us, along with our Dr. R.S. Sri Krishna, known for his orator capabilities and knowledge. So, wishing the CME will be very useful to all of us, not only to nurses, even to the doctors who are attending this program. And this will definitely make them more effective, more competent in providing healthcare to the babies. And I assure once again, we are here to have good coordination with our nursing staff to have these kind of useful academic activities in order to improve our competence to bring out best results for our sick newborns. So thank you for giving us the opportunity. Thank you, Dr. Aparna, Dr. Pranit, Dr. Arasli. Namaskar.
Thank you, sir. And now I request Professor Rajeshwari ma'am. It was her idea and her request that has made this webinar possible. As the president of the Telangana State Chapter, representing the nurses across the state, I request you, ma'am, to please give your address and then we'll begin the presentations. Ma'am, unmute చేసుకో. Ma'am, screen has frozen. Any of you can see her?
No.
Oh, yeah. So I think we'll just wait for a couple of minutes before she joins back. Yeah, she's joined back. Rajeshwari, ma'am, over to you.
Yes, sir.
Yeah, please go
Good
ahead.
afternoon. And PATS, because whenever, like when the students came to me, like asking for the module regarding the module about this pediatrics, I was just remembered Sri Krishna sir. And I thought, okay, I'll request him for my students. Then I thought, sir said, like, why can't we go for the, no, for all the students? Then I really thought that from TNA, I think I have to take a move and request sir, like, how we can do and all. And when I requested, he accepted. Really, I thank you, sir. And I thank all the Pediatric Association. And I feel proud to say that my students are lucky to have this series because like pediatrics, really newborn care is very important for our students because we will be dealing with the deliveries and all. I thought even our teachers, faculty, we have pediatric faculty, even in nursing. Even though they teach, I thought it will be an additional thing if you people will teach. You are always there in the hospital side, the clinical setup and doing deliveries and giving like a newborn care to the babies. I thought my students will be more benefited than with other state people. So this is my thing. So that is the reason I requested. And I tell my students, you are really lucky to have this series. I hope you will understand and please attend and participate actively. And wherever you are not understanding, you can stop and ask, like, ma'am, I'm not following, or sir, I'm not following. Can you please explain? So that freedom, all of them has given. So please take this opportunity and try to learn and enhance your knowledge. Thank you once again to Sri Krishna sir and the team who has arranged this series for our nursing students. Thank you, sir.
Yeah, thank you, ma'am. Now we'll move on with the academic session for the day. So, as part of PATS and TNA's joint initiative to cater to the new nursing curriculum involving pediatric and newborn care, the first module is on neonatal care. Frankly speaking, it will take probably a month and not just webinars, but physical classes and also practical demonstrations for nurses to effectively pick up the fine nuances of newborn care. However, we have been given a task of giving you kind of లాస్ట్ మినిట్ ప్రిపరేషన్ ఎగ్జామ్కి ముందు స్పీడ్గా ఫాస్ట్గా ఎలా అయితే ప్రిపేర్ అవ్వగలమో ఆ టాస్క్ మాకు ఇచ్చారు కాబట్టి వీ విల్ ట్రై టు డూ వాట్ ఎవర్ వీ కెన్ అండ్ వీల్ ట్రై టు కవర్ those those topics which are most important for nurses. I've looked at the curriculum and I realized that there are some core topics which are being asked as core competencies, and these competencies, as I said, will be built up more by practice, but we will try to inculcate that concept in you. And by the end of the next 90 minutes, at least 6 core topics, we will cover key aspects. So quickly, I'll start my presentation. And today's presentations will include 2 of them on breastfeeding and kangaroo mother care, which will be for about half an hour together, followed by a wonderful set of presentations by Dr. Aparna, who is the clinical director and the head of neonatology at Kim's Cuddles Hospital, Kondapur. Thank you, Dr. Aparna, for joining us. We also have Dr. Pranita Reddy, a consultant neonatologist and pediatrician from Kim's Cuddles Hospital. Both of them have vast experience in neonatology, and more importantly, they teach nurses also extremely well. So I'm sure you will benefit from the expertise of the faculty today. And to start with, let us take you through the first presentation. The first one is on breastfeeding. Yes. Yeah. So the first presentation is on breastfeeding. Rajeshwari, madam, you can see the slides, right?
Yes, sir.
Yeah. So the learning objectives are that at the end of this presentation, you should be able to enumerate the advantages of breastfeeding, help the mothers with the correct technique, identify factors that will enhance lactation, and identify the difficulties that are associated with breastfeeding and their solution. What I'll do is the entire presentation will be in English, but when I sum up, I'll try to sum it up in Telugu so that it's easy for you to understand. Most of you have already read this subject, but we'll be looking at the competencies and try to give you additional material and important facts which are related to the core competencies. Before that, let me just keep it a little interactive by asking you to see and answer in the chat box a couple of these questions. The first question, what is the first immunization of a newborn baby? The second question, how does colostrum help in reducing neonatal jaundice? The third question, does breastfeeding promote family planning? Yes or no? Fourth, how do you assess for adequacy of breast milk? And the fifth question, breastfed babies have less chance of developing which of these diseases? Cancer, heart disease, hypertension, or all the above? I'll just pause for a minute for you to answer in the chat box and then proceed with the session.
Dr. Rajeshwari should explain to her nurses to give their answers in the chat box.
Yeah, yes, sir.
Rajeshwari
I
garu.
think they're giving it, yeah, they're giving it there as well. So what I'll do now is I'll quickly go on and we'll come back to this particular slide towards the end. So learning objectives అంటే మనం ఏవైతే కంపల్సరీ ఈ ఆస్పెక్ట్స్ నేర్చుకోవాలి అని కరికులంలో రాసిందో ఆ aspects ki tagga konni questions to start with. Now we will move on to the presentation and I seek your attention for the next 15 minutes so that we can do this session well. So breastfeeding, as we all know, is a inborn activity which the nature or God has given to all newborns. This is something that normally physiologically happens, but there are some constraints and we have to manage these constraints which are there. Breastfeeding should be initiated as soon as possible, ideally within an hour, should be continued for full 6 months. పుట్టిన వెంటనే లేబర్ టేబుల్ మీద ఎక్కడైతే కాన్పు జరిగిందో అక్కడే బ్రెస్ట్ ఫీడింగ్ స్టార్ట్ చేయాలి. లోపల ఐడియల్ గా ఇవ్వాలి. 6 months వరకు 180 రోజుల వరకు తల్లి పాలు మాత్రమే ఇవ్వాలి. సో దీస్ ఆర్ మినిమం, బేర్ మినిమం, అండ్ దీస్ ఆర్ నాన్ నెగోషియబుల్. ఇవి తప్పకుండా చేయవలసిన విషయాలు. Why are we stressing so much on this early initiation of breastfeeding and exclusive breastfeeding for 6 months? Because there are a lot of advantages that breastfeeding gives. The first set is to the newborn. Breastfeeding is the only feeding and the optimum nutrition for growth and development. It protects against infection. It is the first immunization of the newborn baby. Breast milk lo unna immunoglobulins, protective chemicals will protect the baby against all diseases. Appude puttina aa chinna papa, we know that the child is very delicate, very small, but still is as strong as all of us, provided the child gets exclusive breast milk. And breast milk, especially the colostrum in the initial stages, is the best protection and the first immunization for the newborn baby. It is easily available, easily digested. It protects against allergies, including eczema and also asthma, and has a lot of health benefits for the newborn. Apart from these very tangible benefits, it also enhances the bonding between the mother and the baby. The more mother breastfeeds, the better is their attachment towards each other, and this again further influences the breastfeeds. So, all positive stimuli like love, affection, even the fact that the mother is looking at the baby while feeding, all this will increase the hormonal access and ensure adequate milk supply and also sustain it over a period of time. They've done a lot of studies to see what is the IQ of a breastfed baby as compared to a non-breastfed or a top-fed baby. And they saw that breastfed babies have a very significantly higher IQ. So if you want your kids to become doctors, engineers, well educated people of society, then feed them breast milk soon after birth and continue it only giving only breastfeeding for 6 completed months. Breastfed babies also have lesser chance of developing hypertension, diabetes, coronary heart disease, and even cancer in later life. So all these are proven advantages of breast milk. Apart from benefits to the baby, are there benefits to the mother as well? Yes. It accelerates the process of involution of the uterus, so there is lesser chance of postpartum hemorrhage. The bleeding significantly comes down if we are able to immediately establish breastfeeding. Exclusive breastfeeding also works as family planning and delays the next pregnancy by providing 98% protection against conception when the baby is exclusively breastfed during the first 4 months. If you give it, then it works as a natural conception. It lowers the risk of breast and ovarian cancer in the mother. It also reduces the workload for the mother. So it's a big benefit to the baby as well as to the mother. And not just to both of them, it's also beneficial to the family and the society. It is more economical for the mother to feed the baby with breast milk. It promotes family planning. Risk of hospitalization and infection is dramatically lesser in those babies who are breastfed. So it reduces infant morbidity and also mortality. I want you to look at this particular slide and understand the anatomy of the breast, because this will explain the problems that come up during breastfeeding. So if I can just take you through the slide, this part of the breast is the nipple and this is the areola. These white structures that you see coming from the nipple extending into the breast are the lactiferous sinuses. This is where the milk collects. As it leads into the interior part of the breast, it forms the ducts. Next, further, there are milk secreting cells. Milk secretion is helped by prolactin. And now, amidst this, you have muscle cells. Muscles will contract. And what makes these muscles contract? Oxytocin. So, oxytocin helps in contraction. Prolactin will help in secretion of the milk. There are Montgomery glands, and there is a supporting tissue and fat. So the breast consists of partly glandular tissue and supporting tissue and fat. Milk is secreted by this gland. It travels through the tubules. They drain into these lactiferous sinuses. And the sinuses, which store small quantities of milk, lie below the areola. So when they open out onto the nipple through the lactiferous ducts, and there is a thin layer of muscle, the myoepithelium, that surrounds each gland. So this muscle, whenever it contracts, it causes ejection of the milk from the gland. It is important to know where are these sinuses located, where are these ducts located, which is the hormone that governs these activities. After anatomy, look at the physiology. As I said, the positive and negative stimulus plays a big role for success of breastfeeding. If a mother is happy, contented, without any pain, is able to sleep well, and has a lot of affection, love, and affection for the child, then the baby will also behave well. breast baby, then the amount of milk production produced and also secreted, both of them come down. There are two main hormones that we should remember. One is prolactin, another is oxytocin. Prolactin is a hormone secreted by the anterior pituitary gland. Prolactin is for production of the milk. Now this increases at night, and that is the reason first 1 month prolactin, which is responsible for the production, will increase if the baby is being fed at the night. Its secretion also increases by sensory impulses from the nipple. So whenever the baby is suckling at the nipple, the prolactin will increase. And when the breast is emptied after feed or after expression, again it increases to produce the next feed. Prolactin also suppresses ovulation and thus will prevent the next work as a conception, prevent conception, work as a family planning. This is one hormone, which is the prolactin. And as you have seen, it has very clear benefits. Oxytocin is the other hormone. This is secreted by the posterior pituitary. Oxytocin is responsible for ejection of the milk. Its secretion also increases by sensory impulses whenever the baby is suckling. The secretion also increases by the smell, sound, and touch of the baby, and whenever the baby is calm, stress-free, and relaxed. So all these will increase the ejection of the milk from the breast through raising the oxytocin levels. A simple, nice back massage will also increase the secretion of oxytocin. So a calm, stress-free, relaxed, happy, contented mother who's not in pain will have a higher levels of oxytocin, and this plus the smell, sound, touch of the baby and mother and baby being together will increase the amount of oxytocin, and the baby will have better breastfeeding. Apart from these two hormones, there are some reflexes which will help the baby in breastfeeding. These are rooting, sucking, and swallowing reflexes. They help the baby to take the milk which is secreted from the breast. The first one is called as the rooting reflex. I want you to look at this particular rooting reflex which is depicted here. So when something is touching the lips, the baby automatically opens mouth and puts the tongue down and forward. Reflex is something that all babies are born with. Puttu vachinattu. So automatically this will happen. Rooting reflex. Once the mouth is opened, tongue is down and forward, then the baby can take the nipple inwards. The next reflex is sucking reflex. Suck is again a reflex that automatically happens when the baby touches something on its palate. So this is another reflex which is called the sucking reflex. Once the mouth is filled with milk, the child then takes up the swallowing reflex. This allows the baby to empty whatever the baby has taken in, and it goes down and is ready for the next gulp of milk. The skill here is that the mother should learn to position the baby, and the baby slowly learns how to take feed from the breast. However, there is a lot of importance given to the technique of breastfeeding. Although breastfeeding is a natural thing and most of the mothers can feed without any problem, they should know how to prepare themselves for breastfeeding and also address the problems that might come up. There are many ways to breastfeed, and each mother will have her own style to suit her baby. However, some mothers will need some assistance in positioning, attaching the baby to the breast, and these will help in successful feeding. There are two important words that you will learn in this session. One of them is positioning. Positioning ante mother babyని ఏ విధంగా ఇలా పట్టుకుని ఉంది. This refers to the interaction between the mother and the baby as a whole. Look at this diagram. It shows the baby is well supported. The head, neck, and body of the baby are in the same plane. The entire body of the baby is facing towards the mother, and the baby's abdomen, if you see here, is touching the mother's abdomen. This is called as positioning, which refers to the position of the mother and the baby together as a whole. This is positioning, and this is the correct positioning. Correct positioning ఎందుకు important? కరెక్ట్ గా ఉంటేనే పొజిషనింగ్, ద రెస్ట్ ఆఫ్ ఇట్ విల్ బి ఎఫెక్టివ్. ఐఎమ్ టాకింగ్ అబౌట్ అటాచ్మెంట్ నెక్స్ట్. అటాచ్మెంట్ అంటే హౌ ద బేబీ ఈజ్ అటాచింగ్ ఇట్ సెల్ఫ్ టు ద నిపుల్ ఆర్ ద బ్రెస్ట్. This is different from positioning. Attachment is very clearly just the breast and the baby. Baby's mouth is wide open, as you can see here. Once the mouth is wide open, the lower lip is turned outwards, the chin touches the breast, and majority of the areola is inside the baby's mouth. So this is called as good attachment. If the mouth is not wide open, then the lower lip cannot turn outwards, and the mother starts to get pain because the child constantly feeds only on the nipple. You recall this particular slide where I showed you about position of the lactiferous ducts and the sinuses. If you recall, they are not at the tip, they are under the areola, around the zone. So only at the level of nipple మీద suck చేస్తే milk రాదు, దానివల్ల నొప్పి వస్తుంది. So the mouth has to be wide open, lower lip has to be turned outside, chin should touch the mother's breast, as you can see here, and majority of the areola should be inside the baby's mouth. This is called as attachment. It is important to ensure very good attachment, because if there is poor attachment, sore nipples, because of that, milk has started to get produced, but it's not able to come out. So it causes engorgement. Less milk, so the baby will suck more vigorously. Milk బయటకు రావట్లేదు, so the baby gets more frustrated and is not satisfied after a feed. So this gets into a vicious loop, and the baby and the mother cannot come out of it so easily. Effective suckling is the third aspect. It is called effective when the infant shows slow, deep sucks with a little pause sometimes. When the infant is not sucking well, please look for any ulcers or white patches in the mouth. That may be the reason for not suckling well. The last 5 minutes now on breastfeeding, we'll deal with what are the problems. The various problems are, one of them is inverted or flat nipples, which means the nipple is not protruding out or becoming prominent. So the baby is not able to attach itself to the nipple and the breast properly. Many a time this can be diagnosed in the antenatal period when we do a thorough examination of the mother's breast, and these mothers just need some additional support to feed their babies. How is that support done? Through this technique which is called as the syringe inverted nipple or syringe technique. So a syringe తీసుకుని, you cut along this line, you insert the plunger from the cut end and gently you pull the plunger so that the nipple which is flat or inverted now begins to come out. The other issue is sore nipple. This is caused by incorrect attachment. In the chusam kada, the only sucking at the nipple does not get enough milk out, so the baby will suck more vigorously. This results in a very sore nipple. Treatment is the correct positioning and attachment of the baby. Hind milk can be applied to the nipple after a feed, and the nipple should be aired to allow for healing in between the feeds. Third issue is of breast engorgement. The milk production increases during the second and the third day after delivery. In the initial few hours, it will be only a few drops. Later on, it begins to increase. If the feeding is delayed or the baby is not positioned well, then the milk will keep accumulating, and this will result in a swollen, hard, warm, painful breast, which is called as an engorged breast. The treatment is to give early, frequent feeding, ensure that the milk which is getting produced is coming out. You can give local warm packs and analgesics to the mother to relieve pain. Breast abscess is where there is a congested, engorged breast with infection onto the nipple, or the duct is getting blocked. Then the mother will need analgesics and even antibiotics. And the last problem is reduced milk supply or not enough milk. Many mothers complain they do not have enough milk. Reassurance is needed. Most of the time, this is a hormonal cycle. Just like the hormones have helped the baby to grow, to make the pregnancy happen, if all this has functioned, then the milk will also come. You need a very strong reason to not come. It will happen for every mother automatically, unless there is something that will stop it. So find that stopping factor and try to correct it and reassure. And when do you know that the baby is feeding well or there is enough milk? ఎందుకంటే మనకు బయట కనపడదు. You don't know how much the baby is feeding. So how do you indirectly assess? By three factors. One, if the baby is passing urine at least 6 to 8 times in a day, sleeping for 2 to 3 hours after each feed, and there is adequate weight gain of 20 to 30 grams on an average, depends again on other factors, per day. So these three factors will indirectly tell us whether the breast milk is adequate or not. So I want to finish by asking you the same 5 questions again, and let us just revise what we have learned. What is the first immunization of the newborn baby? Colostrum or breast milk. That is the first immunization. How does this help in reducing jaundice? Because this increases the enterohepatic circulation. We know that the jaundice is a physiological thing for all babies. However, if it crosses a certain level, then it becomes a pathological jaundice or something that requires treatment in the form of phototherapy or exchange transfusion. So, under babies ki serum bilirubin increase అవుతుంది. అది నార్మల్ గా కన్వర్ట్ అయిపోయి బయటకు వెళ్ళిపోతుంది. ఆ కన్వర్షన్ అవ్వడానికి ఎక్కువ సేపు ఇంటెస్టైన్స్ లో ఉండాలి. ఎక్కువ ఇంటెస్టైన్స్ లోకి వెళ్ళాలి అంటే ఫీడింగ్ బాగా చేయాలి. డస్ బ్రెస్ట్ ఫీడింగ్ హెల్ప్ ప్రమోట్ బ్రెస్ట్ ఫ్యామిలీ ప్లానింగ్? ఆన్సర్ ఇస్ ఎస్. ఇందాక చూసాం కదా, ఫస్ట్ 4 months లో just the fact of giving exclusive breast milk will reduce the need for contraception. How do you assess adequacy of breast milk? By 3 points, which I just told you: urine of at least 6 to 8 times, baby sleeping very well after a good feed, and the third thing, adequate weight gain. Breastfed babies have less chance of developing what? Cancer, heart disease, and hypertension, and a lot more benefits which the baby has got. So this finishes my first talk, and I'll now take you through the next session, which is on kangaroo mother care. So as I go to the next session, I'll request all of you to please type in your queries in the chat box. Soon after my next session, I will definitely try to answer each of the queries, and we are trying to cover the main aspects as I told you. If there are any more aspects of this which you specifically want a clarification, please feel free to ask us on that. Now, this second talk on kangaroo mother care, this is a very important aspect. The reason being, if there is one intervention that can save the maximum number of newborns, it is kangaroo mother care, because the most important cause of morbidity and mortality is because of prematurity in case of newborns, and the most effective intervention is kangaroo mother care, which means if you had to choose one intervention, you had 100 rupees, you want to spend it on the most effective intervention, it seems it is kangaroo mother care. Kangaroo mother care ante enti? It's a very simple technique. It's a very evidence-based, high-impact interventional technique for standardized care of low birth weight infants. KMC is a simple method. It includes 2 components: early and prolonged skin-to-skin contact, and the second aspect is exclusive and frequent breastfeeding. It is shown that it can prevent up to half of all the deaths in babies who are less than 2 kgs, and all babies who are less than 2 kgs should be started on KMC on priority. It all started in Colombia, where they experimented by tying the baby and the mother together, and then they found that it gave a lot of benefits to the baby. And kangaroo mother care and endukantaru, it resembles the kangaroo. Literally, the kangaroo has a baby which is staying in the womb of the mother until delivery, and after it comes out, బయట ఒక చిన్న pouch లో అక్కడే ఉంటుంది. ఎంతసేపు? బయట ప్రపంచానికి రెడీగా అయ్యేంత వరకు it stays in that little pouch. That is why it is called as a kangaroo mother care, because this is exactly what we are trying to simulate. Why kangaroo mother care? Because effective implementation of this will reduce mortality at discharge and at follow-up, reduces infection, reduces hypothermia, the hospital stay, improves breastfeeding rates, improves the bonding of the mother and baby who are constantly together, and improves the growth of the baby as well. KMC is a unique thing that satisfies all the senses of the infant: the touch, warmth, listening to the voice, the heartbeat can also be felt. All this helps in giving these results for the baby. It's a very simple procedure. I want you all to look at the slide. The infant is placed between the mother's breasts in this upright position. The head should be turned to one side in a slightly extended position. This slight extended head position keeps the airway straight and open, allows the mother and the baby to see each other. Now, the hip ante ikkada it should be flexed and abducted. Oka frog madiriga. Baby should be placed here. And the infant's abdomen should be touching the mother's epigastrium. So this is the correct position of the baby in the kangaroo position. Kinda ninchi, the baby is supported with a sling or a binder. I'll show you how that is done. These are the things which are readily available with us. Even a simple oka chunni kani, cheera, chinna part of the sari kani, that can be used to tie the mother and the baby together. You also have specific KMC devices. So KMC can be provided by putting the mother and the baby together with these KMC supporters or clothes which are supporting them together. Before you finish this, you have to ensure that the baby is adequately clothed, should have cap, socks, disposable diapers, a front open shirt, and all this is meant to give the baby protection from hypothermia. The mother now will be in this kind of a position with the baby together like this. And this mother and baby together can do all activities. They can engage in their regular work. If the mother is comfortable, they can even sleep in the kangaroo position, but in a reclined or a semi-recumbent position. Nadustu, mother and baby stay together. In fact, this was the preferred position for the baby. Time కన్నా ముందు వచ్చేయడం వల్ల బయట ఉంది కానీ this is the best place for the baby, as close to the mother as possible. Now, few terms that you may be asked in the exam: what is short KMC? 4 hours daily. What is continuous KMC? More than 12 hours daily, documented on at least 2 consecutive days. So many benefits from KMC, such a simple procedure. When should you stop it? Once the baby is reaching term or the weight is around 2.5 kgs, the baby by itself starts crawling out, and once it wriggles out and is uncomfortable, it tries to come out of that pouch. That is when you can discontinue KMC. If you have started KMC in the hospital, you can continue it in the house as well. It is called as home-based kangaroo mother care. And this actually KMC is a misnomer. It is just mother okkati cheyavalsindi kaadu. If there you have a caregiver like the father or a grandmother, grandfather, anyone who is healthy and can keep the baby together for a long period of time, should be given the opportunity to do it, because all these benefits this baby deserves, and this will enable the mother also some rest. So the last section now is a small video, and I'll just share this video, and this will give you a little insight on how KMC is done. I'll just switch on the video and then share screen. Yeah, so I have that on. Let me share the screen now, and I'll show you this video of kangaroo mother care. Can someone just confirm if you can see the video?
Yes, Dr. Sri Krishna. Audio రావట్లేదు, video వస్తుంది.
Yeah, that's fine. Yeah, I'm going to give the voiceover. So this is the baby. So baby కి ఇట్లాగా మనం క్యాప్ పెట్టాలి. క్యాప్ తో పాటు మనం మిట్టన్స్ కూడా తొడుగుతాము. And we try to cover all the exposed part of the baby. And now this baby is with a disposable diaper, cap, mittens, and socks, and is now ready for kangaroo mother care. Before we start the procedure, explain to the mother the benefits of KMC, why we are doing it, how long should we do it, and so this is the correct procedure for kangaroo mother care, wherein the mother wears a dress that allows the front part of the chest to be available for putting the baby on and between the mother's breasts, and the mother takes the baby in this kind of a frog leg position. It చూసారు కదా, the hips are flexed, abducted, and the mother can watch the baby from the side when the head is turned to one side. So once this baby is kept in this position, you take a cloth. As I said, any small garment can do. We have special slings as well. ఈ ట్రయాంగిల్ పొజిషన్ లో ఆ క్లాత్ ని పెట్టి ఆ లాంగ్ ఎడ్జ్ ని ఫోల్డ్ చేసి then you take this cloth onto the mother and the baby. You cover the top of the baby like this. ఆ రెండు ఎడ్జెస్ ఏవైతే ఉన్నాయో యు టేక్ ఇట్ అరౌండ్ ద మదర్, చుట్టూ కట్టేయాలి. లిటరల్లీ చీరని కట్టినట్టుగా యు టేక్ ద టూ ఎడ్జెస్ బిహైండ్ ద మదర్ అండ్ యు టై ద టూ ఎడ్జెస్ వెరీ స్ట్రాంగ్. ఈ విధంగా కట్టడం వల్ల ద మదర్ అండ్ ద బేబీ కెన్ బి in the KMC position of the frog leg position of the baby. So the mother holds the baby for now as the two edges are being tied behind, and now the baby is supported by the mother as this is being done, and after this she doesn't need to support much. The kinda unna edge ni we just tuck it in after ensuring that the feet are nicely placed, and you tuck in the lower edge under the feet and ensure that the mother and baby are nicely snugly kept. Ensure that the face of the baby is visible to the mother for monitoring the baby. Once the baby is wound nicely like this, you don't have to hold the baby all the time. This is as good as the baby inside the mother's womb. So the baby will live here, literally. It will stay here. Mother can continue her work. She can continue to walk, eat, and whenever there is a need for breastfeeding, she can directly feed from this position, moving the baby a little towards the breast. So this is the advantage, and this is the correct way of doing kangaroo mother care. This helps in giving all the benefits that we had so discussed to the baby. So that finishes my section. Thank you, everyone. And now I hand it over to Dr. Aparna to take you through the next two sessions. And after her session finishes, I'll get back to you if we have questions in the chat box. Over to you, Dr. Aparna.
Thank you, Dr. Sri Krishna. At the outset, my sincere gratitude to PATS under the leadership of Dr. Sunkoj Bhaskar sir, Dr. N.L. Sridhar and Dr. Sri Krishna for giving me and Dr. Pranita from KIMS this opportunity today to be interacting with so many nurses. And thank you, Rajeshwari ma'am, for having us on this session. So as Dr. Sri Krishna has already said, we shall be discussing total of 6 topics today, 2 of which he has covered. I shall be covering thermal control for newborns and shock, assessment and management of shock in newborns. And then I shall be handing over to my colleague, Dr. Pranita, for the next 2 sessions. I hope the slides are moving and my audio is clear.
Yeah, please go ahead.
Okay. So when we talk about hypothermia, we all should remember that in newborn babies, the vitals are assessed in the order TABC. T for temperature, A for airway, B for breathing, and C for circulation. So temperature control precedes even airway, breathing, and circulation in importance in the assessment as well as stabilization of a sick newborn. Providing warmth to prevent hypothermia is hence one of the most basic and cardinal principles of essential newborn care. Now, if we do not do this, hypothermia can be dangerous and it can lead to a lot of morbidities like hypoglycemia, bleeding, pulmonary hemorrhage, acidosis, sepsis, respiratory failure, and eventually death. Every 1 degree centigrade fall in temperature, particularly in a preterm baby, is said to be associated with a 28% increase in the risk of mortality. So hypothermia is a very, very important risk factor, not only to mortality, but to a number of morbidities in babies. Despite all this awareness, it continues to be very common and is an important cause of neonatal deaths because sometimes we often lack attention to this important and vital aspect of neonatal care. Now, why are we so concerned about hypothermia? Or in other words, why are newborn babies more prone to develop hypothermia compared to older children or all of us, adults? This is because they have a very large surface area in comparison to their body weights. They also have limited thermal insulation due to lack of subcutaneous fat, especially in low birth weight babies. And you know that this subcutaneous fat or brown adipose tissue is responsible for non-shivering thermogenesis. This is deficient in newborn babies. And they are also prone to heat loss due to a number of processes. Some of the times this is physiological, sometimes this becomes pathological processes. Newborn babies lose heat by one of these four important mechanisms: evaporation, convection, radiation, and conduction. Now, this is not just theoretical, but this has a lot of importance in the practical care that we provide to newborn infants. So, if, for example, the baby is covered soon after birth with amniotic fluid and the baby is not immediately dried, then the baby is going to lose heat by evaporative heat loss. So evaporation of amniotic fluid from the skin surface can lead to evaporative heat loss. Likewise, conduction can be the cause for heat loss when the baby is placed in close contact with cold objects like a cold cloth or cold tray. That is why we insist that the newborn baby in the delivery room should be received in a pre-warm linen. Likewise, convective heat losses may happen because of cold air currents in which the cold air replaces the warm air around the baby. So if the baby is placed next to an open window where there is a lot of air draughts, or placed below a fan which is going at very high speed, or in a room where air conditioner is on and the room temperature is well below 25 degrees centigrade, then the baby can lose heat by convection. Newborn babies can lose heat by radiation when they are surrounded by cold or solid objects in vicinity, but may not be in actual contact with the baby. For example, if we place the baby close next to a cold solid wall, baby may not be in contact with the wall, but baby can still lose heat because of radiation. So remember these four important mechanisms of heat loss: evaporation, which is because of evaporation of water or amniotic fluid from the skin surface; conduction, which is when the baby is in contact with a cold object like cloth or a cold tray; convection, when the baby is exposed to cold air currents or draughts like close to a window or fan; and radiative heat losses, when the baby loses heat to a colder object which is in vicinity but not in contact like cold walls. In addition to their inherent physiological predisposition, there are some additional risk factors that make the baby more prone for hypothermia. These are prematurity, intrauterine growth restriction, that is small for gestational age babies, babies born through birth asphyxia or babies who did not cry immediately after birth, and babies with some anomalies like gastroschisis, which may expose the internal organs like intestines to the external ambient environment, leading to a lot of evaporative heat losses. So preterm, IUGR babies, babies born through asphyxia, and babies with some anomalies like gastroschisis, omphalocele are at particularly high risk for hypothermia. Now, when we are dealing with a newborn baby and when we talk about the environmental temperature, there is a concept called as thermoneutral environment. The thermoneutral environment, as you can see in this figure, the shaded lines in the small zone that is in the center of the figure refers to the range of temperature of the ambient environment in which the baby can maintain body temperature without expending or without losing additional energy. So this is a close range of environmental ambient temperatures in which the newborn baby must be ideally nursed. Within this temperature range of the environment, the baby will maintain body temperature without losing excess energy. Outside this thermoneutral range of environment, there is one more range called thermoregulatory range, where the baby may still be able to maintain temperature but by losing additional energy. But outside thermoregulatory range, the newborn baby will either become hypothermic or hyperthermic if we do not control the ambient temperature. So now we have discussed the importance of hypothermia and how it predisposes to morbidities and the mechanisms of heat loss. Let us now discuss something about how to assess for hypothermia. In other words, how do we measure the temperature? Now, the common method we all follow is the palpation with the dorsum of the hand. We generally tend to palpate the baby's abdomen and the baby's peripheries, the hands and feet. If the hands and feet are as warm as the abdomen or the center of the body of the baby, then the baby is said to be euthermic. If the hands and feet are cold, but the abdomen alone is warm, then the baby is supposed to be in cold stress or mild hypothermia. This temperature measurement is somewhat crude, and hence we generally use a thermometer for more reliable measurement of temperature. There are multiple sites in which temperature can be measured, such as axillary, rectal. These days we also have tympanic thermometers and forehead. So let me just show you a short video on measurement of temperature in a newborn baby. Kindly confirm if the video is playing.
Temperature. The baby is kept warm through procedure. Take the thermometer from its container, clean it by spirits swab from one end. Shape it by holding the other end. Note the reading. It should be less than 35 degrees Celsius. Place the bulb end under the baby's arm, in the middle of the armpit, near the point of action. Remember, the thermometer should be kept static. Gently hold the baby's arm against the body. The temperature of this baby is 37 degrees Celsius.
So you can note that the thermometer bulb is placed in the axilla, and the thermometer itself is placed parallel to the baby's trunk and not perpendicular to it. And there is no need for us to add or subtract 0.5 or 1 degree centigrade, which is often done as a convention. Whatever temperature you are noting down, you can record the same temperatures as the temperature of the body. Now, these days, we also have the digital thermometer, which does not mandate you to kind of shake or prepare the mercury level of the thermometer prior to the assessment. You can directly switch on the button on the digital thermometer, place it in the axilla, making sure that the bulb of the thermometer is completely within the baby's armpit, and wait for the beep sound, which indicates completion of temperature assessment. Now, there are different signs and symptoms that babies can exhibit when they develop hypothermia. These include apnea, shallow breathing, lethargy or decreased activity, hypotonia with diminished reflexes, pale motile skin which can appear cool to touch, and they may also develop poor feeding, poor gastric emptying, and abdomen distension. There are various techniques of temperature recording as we just discussed. The axillary temperature is as good as the rectal temperature and is much safer because of lesser risk of injury, infection, and sometimes even rectal perforation that can happen with the rectal thermometer. Digital thermometer is now easily available, and it needs to be switched on prior to recording of the temperature. And as we saw in the video, one must record the temperature by placing the bulb of the thermometer against the roof of the dry axilla. Make sure that if the axilla is wet or is covered with vernix, you gently wipe it with a clean gauze or cotton. The baby's arm is held close to the body to keep the thermometer in space, and the temperature is read as it is when the thermometer beeps. In a radiant warmer or an incubator, we also use a thermistor probe or a temperature measurement probe, which continuously records the baby's skin temperature. The thermistor probe must be attached to the skin over the upper abdomen, particularly over the right hypochondrium, which is the area corresponding to the baby's liver. Note that this is the most preferred temperature for the attachment of thermistor probe, but sometimes when we place the baby prone, we can attach the temperature probe to the baby's groin. How do we interpret the temperature that is recorded? Now, neonatal hypothermia is a very common alteration of thermoregulatory state of the newborns, and hypothermia is said to occur when the axillary temperature is below 36.5 degrees Celsius. The normal range of temperature for a newborn baby is 36.5 to 37.5 degrees Celsius. Cold stress or mild hypothermia refers to temperature between 36.0 to 36.4 degrees Celsius, or it is just below 36.5. Moderate hypothermia, in turn, refers to temperature between 32.0 to 35.9 degrees Celsius. And severe hypothermia denotes temperatures below 32 degrees, and these represent very grave outlook, and very urgent skilled care is required urgently in order to ensure the safety of babies in severe hypothermia. So I repeat, 36.5 to 37.5 Celsius is normal, 36 to 36.5 mild hypothermia, 32 to 35.9 moderate hypothermia, and less than 32 severe hypothermia. We discussed about the assessment of baby's temperature using the crude method of human touch and the grading of hypothermia. This is also available in degrees in Fahrenheit. So based on the scale that you use, you can either look at the temperature assessment definition in Celsius or in Fahrenheit. Now, although signs and symptoms in hypothermic baby may be subtle and non-specific, it is important to have high index of suspicion for hypothermia. So if you find a low birth weight baby or a preterm baby looking lethargic or feeding less in your routine postnatal rounds, always have hypothermia high on your list in the list of suspicion or differentials. Let us now discuss a little bit about how to prevent and manage hypothermia. The common situations where hypothermia can occur are in the delivery room, during changing of the baby's nappies or clothes, when there is malfunctioning of a heat source or removing the baby from the heat source, or during the transport of a sick baby. Now, there are major aspects of a cold chain. Likewise, there is a concept of warm chain when it refers to the prevention or management of hypothermia. The following are the important components of warm chain. So warm chain is a set of interlinked interventions carried out at birth and later which minimize the likelihood of hypothermia in newborns. This begins with warm resuscitation or a warm labor room. The WHO recommends that the labor room temperature must be more than 25 degrees Celsius. So if you are in a cesarean OT, then ensure that the air conditioner is switched off well in advance before the baby arrives. This is followed by immediate drying of the baby and immediate skin-to-skin contact between the baby and the mother. Early initiation of breastfeeding, and you all know that breastfeeding is to be initiated within 1 hour from birth. Ideally, you should postpone bathing and weighing of the baby until the baby stabilizes. At least for the first 24 hours, bathing is definitely not recommended, and most guidelines would recommend bathing only after the umbilical cord falls off or in a low birth weight baby after the baby crosses 2,500 grams. Likewise, appropriate clothing of the baby and bedding. When we say appropriate clothing, we refer to at least 2 layers of additional layers of clothing over and above the number of layers that adults routinely feel comfortable at that ambient temperature. So if you are in hot summer wherein we all feel comfortable with a single cotton layer of shirt or scrubs, then the newborn baby will require 1 plus 2, that is 3 layers. Number 7, keeping the mother and baby together. Then we have warm transportation. That is, whenever the baby needs to be transported, make sure the baby is either nicely swaddled and covered with a cap, socks and mittens. Alternatively, the baby can be transported in a more sophisticated gadget like a transport incubator, or if it's not available, on skin-to-skin contact over the mother. And lastly, awareness raising of the healthcare provider, which is a very, very important link. Now, when we talk of warm delivery rooms, the delivery room temperature, whenever you have a room thermometer, must be always maintained more than 25 degrees. Make sure windows are closed and the room is free from draughts of cool air. Preferably, fans must be switched off and the baby should be received on the radiant warmer, which is already switched on and placed at 100% heater output in the manual mode. The pre-warm linen must be used for receiving the baby, and these should be kept warm well in advance to the arrival of the baby. Skin-to-skin contact is recommended to be initiated within the first minute of birth, and this must be continued at least for the first 60 minutes. And it is found to be associated with a lot of benefits, like promoting the early initiation of breastfeeding, reducing the stress levels and serum cortisol levels in the baby, and also for ensuring the thermal transition. In a preterm baby below 32 weeks, as you can see in these two figures, it is imperative that we are ready with a cling wrap or a clean polythene wrap, where we receive the baby directly into this polythene wrap even before drying the baby. Now we have commercially available polythene wraps which allow provisions for providing bag and mask ventilation or umbilical venous access, and the baby need not be disturbed from this cling wrap until the baby is transported to the NICU and the admission temperature is assessed. Now, during transport of a small baby, it is important to ensure that the baby is effectively clothed with multiple layers of cotton and preferably the scalp, which is the largest surface in the baby's body, must be covered with a cap. And likewise, the peripheries, the feet and the hands must also be covered with socks and jablas. Wherever possible, when the mother is there, try to transport the baby on skin-to-skin contact as shown in this figure. And if neither the mother is available nor a motivated caregiver, you should have a sufficient warming equipment such as exothermic thermal mattress as shown here, the Embrace transport incubator, or a fully equipped transport incubator, ideally to ensure that the baby doesn't develop hypothermia en route. Now, while at home, while in the community, it is important for us to sensitize parents to be kind of watchful for hypothermia and take all the appropriate measures like keeping the room warm, practicing kangaroo mother care in low birth weight babies continuously. 24 hours per day also KMC can be practiced, wrapping the baby nicely and ensuring optimal breastfeeding. So there are various techniques to be followed when we detect the baby already in hypothermia. In mild hypothermia, where the temperature is between 36 to 36.4, usually maintaining the room temperature optimally between 25 to 28, starting skin-to-skin contact with the mother, breastfeeding, and ensuring adequate clothing to the baby will be enough to bring the baby back to euthermia. Assess the temperature back in 1 hour and ensure optimal breastfeeding. Whereas a baby who is in moderate hypothermia, where the temperature is between 32 to 35.9 degrees, will definitely need additional warmth using a radiant warmer or an electric bulb wherever warmer is unavailable. If an incubator is available, you may also use an incubator to do this. Do look for a blood glucose level, and if it is below 45 milligram per deciliter, start treatment for hypoglycemia. Reassess temperature every 15 minutes and take steps to ensure that the baby is brought back to euthermia as early as possible. If the baby's rise in temperature is not satisfactory, you may have to increase the heater output on the radiant warmer. In babies with severe hypothermia, where temperature is less than 32 degrees, one must remember to rapidly rewarm the baby till the baby reaches at least 34 degrees, and this must be followed by slow rewarming. For rapid rewarming, you place the baby under the radiant warmer, connect the skin probe and set the temperature setting directly at 34 degrees Celsius. And usually the warmer heater output will become 100%, ensuring that the baby rapidly reaches 34 degrees. Following this, you can keep the set temperature at 0.5 degrees centigrade increments in order to ensure more slow rewarming. In addition, these babies may require treatment in the form of starting oxygen therapy, maintenance IV fluids, giving 1 dose of vitamin K to prevent DIC, actively watching for hypoglycemia by measuring blood glucose. If less than 45 milligram per deciliter, start treatment for hypoglycemia and look for other complications like infection and pulmonary bleeding and frequent reassessment of temperature. A brief note about hyperthermia before I conclude this talk. Hyperthermia is also a common morbidity in places like Telangana, where in summer the temperature can soar up to 44-45 degrees centigrade. Fever or hyperthermia denotes temperatures more than 37.5 degrees Celsius, and they are often due to environmental causes, but sometimes it can be a cause for neonatal infection, especially in a term neonate. So in all febrile neonates, one must diligently search for a potential source of infection like an abscess, meningitis, pneumonia, a viral infection, urinary tract infection, etc. So when you receive a baby who is hyperthermic, see whether environmental hyperthermia is there. See whether the baby is overdressed in multiple layers of woolen clothing or more than 4 layers of cotton, because wrapping the baby too much in hot summer can also lead to hyperthermia. The newborn baby may have been kept too close to a heater or a hot water bottle, or might have been left sometimes under the radiant warmer on the manual mode without proper monitoring of the skin temperature. Now, management of hyperthermia involves addressing the underlying cause. If the environmental temperature is above 39 degrees, the neonate should be undressed and sponged with tepid water of approximately 35 degrees. Don't use cold or ice water for sponging. And do this until the temperature drops to less than 38 degrees. Give frequent breastfeeding to replace fluids. And if the baby is too sick to breastfeed, then the baby must be given expressed breast milk. And if the baby is not able to tolerate this, intravenous fluids. And examine the hyperthermic baby for evidence of infection. So let me conclude this session on thermal control by a brief video on early skin-to-skin contact.
Baby on mother's lower abdomen. Apply the first clamp near the placenta after 30 seconds of delivery, and the second clamp away from the baby. Cut the cord after 30 seconds. Both short-term and long-term of delayed cord clamping. Thank you.
So this video actually spoke about the benefits of delayed cord clamping, which is another closely linked intervention. But we also saw how the baby is placed immediately after birth on early skin-to-skin contact. This provides early thermal transition, and it also helps the baby to be placed on the mother's chest right after the normal delivery. And this also promotes early initiation of breastfeeding. So are there any comments, questions from the nurses on thermal control, or shall we proceed with shock?
Yeah, go ahead, Aparna. Go ahead. There are a couple of questions. I'll put all of them at once after this session.
Okay, okay. So since we are kind of running a little short of time, I'll try to keep this very brief. Now, shock, in this presentation, we shall be discussing on how to identify shock. We shall enumerate some common causes, and then we'll briefly discuss about the two important aspects of shock management, which is fluid resuscitation and the use of vasopressor drugs. So shock and hypotension are not the same thing. Now, shock refers to a clinical state where there is poor perfusion of the body tissues and the body's demands of oxygen and nutrients are not met. Hypotension only refers to a blood pressure record that is lower than the expected reference range, and this is one of the late signs of shock. So remember that one should not wait until the baby develops hypotension in order to identify or treat shock. Now, sepsis, again, which is one of the common reasons for shock, can be in the form of early onset or late onset sepsis. Early onset sepsis refers to appearance of the signs and symptoms of infection within 72 hours of birth, and the usual source of pathogen is maternal genital tract or the delivery area. Whereas late onset sepsis refers to sepsis wherein the signs and symptoms appear after 72 hours and the pathogens are usually nosocomial or hospital acquired. So shock can be of multiple reasons. Let us remember 4 broad reasons to keep it simple. Hypovolemic shock, wherein there is decrease in the effective circulating blood volume. Hypovolemia refers to low intravascular volume leading to shock. The second common reason is cardiogenic shock, wherein there is decreased myocardial contractility or decreased cardiac function leading to shock. The third common cause is obstructive shock, where there is obstruction to the blood flow to the tissues. This can happen either with some heart problems like coarctation of aorta, or it can happen with lung conditions like tension pneumothorax, where there is something that is mechanically stopping blood from perfusing the tissues. And lastly, we have distributive shock, wherein both the blood volume and cardiac function are reasonably normal, but there is some problem in the vasomotor tone. The blood vessels of the baby are either excessively constricted or excessively dilated, leading to shock. So, some common examples of these 4 categories are: you have hypovolemic shock when there is blood loss because of twin-to-twin transfusion or a birth injury. So when the baby had a massive cephal hematoma or subgaleal bleed, sometimes the baby loses so much of blood. Or when there is DIC, intracranial bleeding, pulmonary bleeding, or excessive insensible water losses from the skin, like a preterm less than 1 kg baby. If the baby is managed in a radiant warmer, without humidification, without an incubator, and we did not give adequate intravenous fluids, then the baby can develop hypovolemia related shock. Cardiogenic shock or shock due to low cardiac function often can be seen with birth asphyxia when there is hypoxic damage to the heart, also in some congenital heart diseases, or in preterm babies with a large PDA, or in arrhythmias where there are ECG rhythm problems leading to low cardiac output. Obstructive shock can happen with congenital heart defects like coarctation or aortic stenosis, or lung problems like huge tension pneumothorax, where there is a mechanical restriction to the cardiac output. And distributive shock is often seen due to the loss of vasomotor tone, and normally we see this type of shock with sepsis. Now, how do we assess shock? One of the common signs, clinical signs that you all should know as nurses taking care of newborn babies or children is assessing the capillary refill time. CRT is checked by pressing over the central part of the baby's body, such as the sternum. Usually, we use the skin over the manubrium sterni for checking CRT in newborn babies. CRT over the peripheries, like pressing over the soles of the baby or palms of the baby, is generally not recommended for newborn babies because even hypothermia or polycythemia can lead to prolongation of the peripheral CRT. So how do you check the central CRT? We should apply gentle pressure over the skin over the baby's sternum for a period of 3 to 5 seconds. Often you press and count 1001, 1002 and 1003 to indicate 3 seconds, and then you slowly release this place. So this will result in initial blanching of the skin followed by reperfusion. So observe how fast there is reperfusion or how fast the skin again becomes pink after you release. The normal capillary refill time for a newborn baby must be less than 3 seconds. That is, after you release, the skin must again become pink within 3 seconds. Prolongation of CRT more than 3 seconds is an indicator of poor perfusion and can be one of the reliable indicators of shock. But remember that not one indicator is 100% reliable to assess shock. So you often have to look at multiple parameters. This is one of the indicators for shock, but this can also be prolonged with other conditions like hypothermia. Now, the other clinical features of shock would be to assess the pulse volume, poor peripheral pulse volume, the presence of abnormal color such as the baby looking pale or whitish in color, the appearance of a net-like pattern which is called cutis marmorata or mottling of the skin, the extremities of the baby appearing to be cold, decreased urine output, that is urine output below 1 ml per kg per hour, and the baby being excessively lethargic, obtunded are all the other signs of shock. Low blood pressure or BP less than 5th centile is one of the late signs of shock, and hence one should never rely solely on the blood pressure to identify shock. Now let me just again show another video to you on assessment of the non-invasive blood pressure in newborn babies. So these are all videos taken from the AIMS WHOCC, and these are readily available on the website.
Observe hand hygiene for measuring the non-invasive blood pressure. Place the infant in supine position with limb extended. The first step is selecting an appropriate site. Monitor other certain factors such as pulse oximetry, which also use the pulse for determination of values. The second step is appropriate cup size. Measure the arm circumference and select the measurement should be performed at least an hour after feeding or any medical intervention. Tie the baby cuff and wait for 15 minutes while keeping the baby calm.
So I think you got an idea about checking the non-invasive blood pressure. So important thing is to choose the correct size of the BP cuff wherein the width must be around 40% and the length must be around 80 to 90% of the mid-arm circumference of the baby. Now, having identified all the signs of shock, the last step is to treat shock. How do we treat it? Again, remember TABC, temperature, airway, breathing, and circulation. So treat the baby to prevent hypoxia. Target saturations must be maintained between 90 to 94% by adequate supplemental oxygen. Look for hypoglycemia and correct hypoglycemia. And also another important electrolyte here is to look for hypocalcemia and correct hypocalcemia if it is present, and optimize the baby's temperature to normothermia. Now, the first step while you treat shock is to fill the intravascular tank, which is the intravascular fluid volume. So wherever there is hypovolemia, or even if you are not sure whether there is hypovolemia, it is still safe to give one fluid bolus of 10 ml per kg of normal saline over 20 to 30 minutes in a baby. So if the baby is weighing 3 kg, you are quite safe and okay to give 30 ml of normal saline over 30 minutes to 60 minutes in order to correct any hypovolemia. But before giving the second fluid bolus, especially if the BP and the heart rate did not improve, then we need more reliable assessment of the intravascular volume, which the doctors will be guiding you by looking at certain things like the CVP or the intravascular volume on an echo. Whenever we give the volume bolus, the improvement we are expecting would be a fall in the heart rate by at least 10. So if the baby had tachycardia of 180, you expect the heart rate to come down to at least below 170 and an improvement in the perfusion as measured by the capillary refill time. If this doesn't work, then we resort to the use of vasopressors. Vasopressors are drugs that increase the blood pressure, and some drugs help in increasing the cardiac output by various mechanisms. Some important drugs that we use often are dopamine, adrenaline, noradrenaline, and there are others such as dobutamine and milrinone. Now, I will not go in detail into the mechanisms of actions of these drugs because these can take a lot of time. But let us just conclude this session by a simple formula for calculating the dosage of dopamine that is to be given. So supposing you have been asked to start dopamine infusion for a baby who is weighing around 2.5 kg and you do not have immediate access or instructions on how this is to be started. Assume that you are going to start with a dose of 10 mics per kg per minute. Remember, dopamine can be given between 5 to 20 micrograms per kg per minute. So this baby weighing 2.5 kg, the baby should be given 10 micrograms into 2.5 kg, which is weight, that is 25 microgram per minute. So 25 microgram into 60 minutes, that is 1500 microgram every hour. And in the whole day, this will become 36,000 micrograms per day. So this is a simple bedside calculation that any of you can do. So you need to give 36 microgram, which is the same as 36 milligram or 0.9 milligram of dopamine over 24 hours. Each ml of dopamine has 40 milligrams and hence 0.9 ml of dopamine will contain 36 milligram. So simple calculation is that you need to add 0.9 ml of dopamine solution to make 24 ml of total fluid. And if you run it at 1 ml per hour, then you would be giving 10 microgram per kg per minute. Likewise, there are some other simple formulae for calculating the rate of infusion. So you can also use the formula 15 into the baby's body weight. Say if it is 3 kg, 15 into 3, 45 milligrams of dopamine should be taken. And this is to be mixed with 24 ml. And when this is run at 1 ml per hour, this will be giving the same 10 microgram per kg per minute. So in case the baby does not improve with dopamine, then we look at other parameters, either addition of adrenaline or we may look at dobutamine addition wherever the baby has signs of poor peripheral perfusion. Now, dobutamine is available as 1 ml equal to 50 milligram in contrast to dopamine, which is 1 ml equal to 40 milligram. And this must be used for the calculation of the doses appropriately. When a baby doesn't respond to multiple inotropes, we sometimes suspect a condition called as catecholamine resistant shock. So this is to be considered when the baby doesn't respond to more than 20 microgram per kg per minute of dopamine and dobutamine. And then hydrocortisone is generally given. Some units may give a loading dose of 5 milligram per kg. And this is followed by a dose of 1 milligram per kg given 6 to 8 hourly based on the type of shock. While we are managing shock, the therapeutic endpoints that we should try to reach are a capillary refill time less than 3 seconds, normal heart rate, normal pulse volume, warm extremities, adequate urine output more than 1 ml per kg per hour, and a normal blood pressure. Remember that we should target all these parameters and not just chase the normal blood pressure. So I think I will stop here and probably skip these practice questions because we have 2 more sessions. Instead, I will take up any doubts or questions that have been posted in the group. Dr. Sri Krishna, I hand over back to you.
Yeah. 2 questions, Aparna. You can take the one on breastfeeding as well. One is on if the mother has any breast cancer or any problem related to the breast, whether she can breastfeed. The second one, what are the causes of not getting enough milk in the first 2 days?
Okay, so the only absolute contraindication for breastfeeding is a mother who is on anti-cancer drugs. So if there is a mother with malignancy, breast cancer, who is on chemotherapy, therapeutic drugs, then this becomes a contraindication for breastfeeding. And what was the other question?
Most common cause of not getting enough milk first 2 days.
Okay, most common cause is, I think, delayed initiation of breastfeeding. We all know that early initiation of breastfeeding, less than 1 hour, is strongly recommended by the World Health Organization. Now, failure to initiate breastfeeding early, failure to start skin-to-skin contact early, and failure to, give frequent night feeding, failure for complete emptying of the breastfeeding, and ensuring optimal latch. These are all some common practical reasons for inadequate breast milk production.
Yeah. Last question, Aparna. What is the most common cause of shock? I think this is what that question meant. They said most common shock. Okay. So what is normally, you described the 4 types. What is the most common and which of these medicines would be needed there?
Now, depending upon the type of unit that you deal, the cause of shock will be different. But one thing we should remember is cardiogenic component of shock is almost universal in neonatal shock. So irrespective of whether you're dealing with, sepsis and distributive shock, or if it is a baby with a congenital heart disease like coarctation, newborn babies have very, very vulnerable cardiac function, and in almost all different etiologies, distributive, obstructive, sometimes even in untreated hypovolemic shock, we may end up seeing a component of cardiogenic shock because they can have both systolic and diastolic function inherently being compromised because of their physiological parameters and age. So cardiogenic shock is something that is to be almost always kept in mind while dealing with any cause of shock. So as clinicians, the implication for us is you can safely try up to 1 fluid bolus of normal saline 10 ml per kg when you're dealing with shock if you still don't know what caused it. But beyond that, make sure you have some idea of the underlying reason for shock so that you can titrate your vasopressors. And always remember that the optimal delivery of vasopressors is important. Optimal line is required. Prolonged administration of dopamine or adrenaline through a peripheral line can become ineffective. Remember the correct dosing also, and always optimize volume, calcium, and pH if you want to get the correct response to inotropes.
Yeah, thank you. Thank you, Dr. Aparna. Very insightful session. And any precautions for using the rectal thermometer? One of the questions.
Okay, so as we discussed now, axillary thermometer has almost completely replaced the rectal thermometer simply because it is as reliable as the rectal and it is much safer. So please try to avoid using rectal thermometer. Wherever possible, use the axillary thermometer because you get the same information. If in case you're using a rectal thermometer, say for some reason, then make sure it is never over inserted. The maximum depth of insertion for a rectal thermometer is around 3 centimeters, and try to keep it at around 2 to 3 centimeters for measuring the thermometer. We have had instances where a simple rectal temperature monitoring led to a serious gastrointestinal perforation, and there has been even death of a newborn baby because of such a very small step. So try to avoid rectal thermometer assessment wherever possible. Please use axillary thermometer, and these days you have good digital thermometers. Infrared, not very reliable in newborn babies. A digital contact thermometer placed in the axilla might be the best way of measuring temperature.
Thank you. Thanks for a very insightful session. Yeah. Now it's our pleasure to invite Dr. Pranita. She is a consultant pediatrician and neonatologist at KIMS Cuddles Hospital. Over to you, Dr. Pranita, to take forward the session. And if there are any queries, I'll ask you after you finish. Over to you.
Thank you, Sri Krishna sir. Good evening, everyone. A warm welcome to all our nursing colleagues. I would like to thank IAP PATS, Dr. Sunkosh Bhaskar sir, Dr. Sri Krishna sir, Dr. Sridhar sir, our mentor Aparna madam, and Dr. Rajeshwari madam for this wonderful opportunity. So I would like to start with the first topic without further ado. My first topic is on feeding in low birth weight babies. So low birth weight babies are babies whose weight is less than 2.5 kgs. Is the screen visible, sir?
Yes, screen is visible. We need to see the presentation. Yeah, presentation is on. It's moving as well. Over to you.
Okay, thank you, sir. So we'll discuss the topic under the following headings. Why is nutrition important? What are the goals of nutrition? What, when, and how to start feeds, and assessment of feeding intolerance. So why is nutrition so important? In preterm babies, especially in low birth weight babies, there is increase in weight and increase in head circumference. Almost it triples from the second trimester to the third trimester. Maximum of all the nutrients like glucose, proteins, calcium, iron, magnesium, lipids, all of them get transferred in the last trimester. And also the brain increases 3.5 times the size in the last trimester. Why is optimal nutrition so important? Because it has many short-term effects like protection from infections, avoidance of metabolic bone disease. It also reduces the chances of retinopathy of prematurity, also helps in early discharge. Not only this, it has many other long-term effects like it also improves the subsequent growth. It has better neurological outcomes, better brain growth, better IQs. Also, some of the adult onset diseases like obesity, heart attacks, strokes also are lesser. So first we'll start with minimal enteral nutrition. So I hope most of you must be managing the preterm babies, extreme preterm babies like 28 weekers, 30 weekers. So do we start feeding on day one for these babies? So on day one, we usually start something called minimal enteral nutrition or trophic feeding. This is usually started in babies less than 32 weeks. So we start with expressed breast milk or mother's own milk in a quantity of 10 to 15 ml per kg per in divided feeds. So say your baby is 1 kg, we're going to give at least 10 ml feeds in 24 hours. We can give at the rate of 1 ml every third hour. So this is started on day one, and then we are going to advance the feeds based on the feed tolerance. So what are the contraindications for this kind of nutrition? Ventilation, respiratory distress are certainly not any contraindication to start feeds for preterm babies on day one itself. So the other contraindications are babies with intestinal obstruction, NEC, or shock. So once the baby starts feeding, we are going to slowly progress at the rate of 10 to 20 ml per kg per day. And so as we just discussed, these are not contraindications for trophic feeding, like umbilical arterial catheter, indomethacin therapy, RDS, mechanical ventilation, CPAP, asphyxia, and shock. The only contraindication is intestinal obstruction or ileus. So once we start feed, how are we going to give the feeding? This depends on the gestational age of the babies. Babies who are born less than 28 weeks of gestational age usually do not have good sucking efforts, and they also have very poor intestinal motility. So for these babies, though we start on trophic feeding, parenteral nutrition or TPN is the main modality of feeding. And we are going to slowly progress the feeds based on the baby's feed tolerance. In babies born between 29 to 31 weeks of gestation, the feeding skills are baby slowly starts developing sucking bursts, but still there is no coordination between sucking, swallowing, and breathing. And hence, in these babies, gavage feeding, that is either nasogastric feeding, NG feeding, or orogastric feeding, that is OG feeding, will be the main modality. In babies born between 32 to 34 weeks of gestational age, these babies start developing little mature sucking, and there is also better coordination between swallowing and breathing. And hence, we can start feeding these babies with spoon or paladay or cup feeding. In babies who are more than 34 weeks of gestation, the sucking efforts are much better. There is also better coordination between swallowing and breathing. And hence, breastfeeding is the main modality in these babies. So whatever modality of feeding you're starting with, still you have to keep monitoring the baby, checking the baby. Is the baby taking the feeds well? Is there good coordination between sucking, swallowing, breathing? Is there any gasping, any spillage, any respiratory problems because of the feeding? So once you started the baby on breastfeeding, but if you feel the suck is not good, baby is not taking the feeds well, then you're going to go one step back and feed the baby either with a spoon, palade, or cup. Similarly, if the baby is having problem with spoon feeding or cup feeding, there is a lot of spillage, there is a lot of coughing, then you're going to go back again one step and start feeding with gavage feeding. Now let us compare nasogastric feeding versus orogastric feeding. So OG feeds are usually easier to insert, but they get frequently displaced and may become costly for the parents. And most of us must be using OG tubes itself because it is more physiological. But the choice again depends on the expertise of the nursing colleagues. NG tubes are easier to fix, but they are less prone for displacement. And it also increases the obstruction in the nasal impedance also increases. So the choice depends on the unit and the expertise of the nurses. So let us see a video. Here our nurses are introducing the OG feed. So under complete aseptic precautions, they have washed their hands, they wear gloves. Now they have taken the NG tube, either 5 size or 6 size, depending on the gestational age and weight of the baby. Next, we are going to measure the distance between tip of the nose to the tragus to the Zippy sternum. After noting the length, we are going to insert it slowly through the mouth. If there is any resistance, we are going to stop. And after putting the required length, we are going to check whether the tube is in the right position or not. So that is confirmed by placing the stent on the stomach. We are going to gently push 2 ml of air and we are going to hear a sound. Then they are going to take a milk which is already prepared and they are going to give it through the syringe connected to the OG tube. So we are not going to push it. We'll gently pull it syringe and it gets absorbed by gravitational force. So in this video, our sister is preparing the feed. So here formula feeding is being prepared. Again, under complete aseptic precautions, she has worn a gloves. She has taken sterile containers with distilled water. Now she's taking the required amount of the formula powder and mixing it in the container. Lukewarm water has to be taken. So we have to mix it well. And then we are going to feed this milk to the baby. Now in this video, let us see how our sister is going to feed the baby using a paladine. So again, here the feed is already prepared. Now she's taking the required amount of calculated feed in the paladine. She's going to feed the baby gently with the milk in the paladine. So we have to keep watching the baby, see the baby's color, breathing efforts, the baby taking well. So do not push in the feed. The feed should be given in the corner of the mouth. So we have seen how and when to start feeds. Let's see what milk to start with. So WHO recommends that mother's own milk is the best form of nutrition. If mother's own milk is not available due to any reason, then the next best form of nutrition is going to be donor mother's milk. If human bank facilities are available, this is the best milk. If that is not available, we can give freshly expressed donor milk, followed by preterm infant formula. And if preterm infant formula is also not available, only then term formula is given. But that should be the least opted variety. What are the benefits of mother's milk in premature babies? So mother's milk reduces much of the problems of preterms like necrotizing enterocolitis, sepsis, chronic lung disease, retinopathy of prematurity. It also decreases the days of hospitalization by 50%. It reduces the cost and it also reduces the duration of rehospitalization. It also improves better neurological outcomes. And how frequently should we give? Should we feed every hourly or 2 hourly or 3 hourly? So there is no evidence for hourly feeding, and in babies weighing less than 1250 grams, we can feed 2 hourly. And in babies weighing more than 1250 grams, third hourly feed can still be given. So now we have started giving the feeds. We need to assess, is the baby tolerating feeds well or not, or is there any feed intolerance? So how do we measure feeding intolerance in babies? What are the parameters we routinely use? So in our unit, we usually measure abdominal girth at baseline. Then before every feed, we are going to check the abdominal girth, especially if the abdomen is clinically distended or if the pre-feed residuals are more. So in case the abdominal girth is increasing by centimeters or there is persistent or altered vomitings, then we are going to aspirate the contents and see. If the volume of content is less than 50% of feed volume, say you're giving 10 ml of feed, but the aspirate is almost 2 ml or 3 ml, in that case, you can just push back the contents and you need to assess the abdomen, see for any local causes. But in case the aspirates are clear, but it is more than 50% of feed volume, that is, you have given 10 ml, but the aspirate is almost 7 ml. In that case, we can withhold one feed and we can continue monitoring. But in case there are blood tinge aspirates, there is bilious vomiting, or there is persistently bilious aspirates, in that case, it is better to evaluate for any systemic causes, NEC, sepsis, and withhold feeds for 24 to 48 hours. So this is about feeding in low birth weight babies. Now I'll quickly go into my next topic, which is neonatal resuscitation. So a baby who is crying actively is a delight to the mother, to the pediatrician, obstetrician, and all the nursing colleagues. Why is it so important? Because asphyxia still contributes to almost 23% of all the newborn deaths. And the most important thing is asphyxia can be completely avoided by adequate antenatal monitoring and by knowing the resuscitation practices properly. So each one of us, all the pediatricians, all the nursing colleagues, all the obstetricians should be efficient in knowing the proper resuscitation of a newborn baby. So out of 100 newborn babies, 90% may not require any resuscitation. But 10% of the babies will require resuscitation and 1% will require extensive resuscitation. So let us see what are the ABCs of resuscitation. In contrast to adults, in babies, temperature forms the main component of resuscitation, followed by airway, breathing, circulation, and drugs. So before any delivery, we need to have a checklist and we need to keep all this equipment ready. The first one is temperature. For temperature, we need a warmer. It has to be kept giving 100% heater output. And in case if there is a preterm delivery, we also need to have plastic bags and plastic wraps, blankets. For airway, we need bulb syringe, suction catheter. For ventilation, we need oxygen blender, devices for positive pressure ventilation, OG tubes, masks. And for oxygenation, we need equipment to give free flow oxygen. For intubation, we need laryngoscopes and ET tubes. And also we need medications like epinephrine, normal saline. So coming to the initial steps. Once the baby is born, the first we need to assess three main things. Is the baby born at term gestation? That is baby born after 37 weeks of gestational age? Does the baby have good tone and power? Is the baby breathing and crying? So if all this is true, we are going to keep the baby along with the mother and carry out our initial steps. So here there are two pictures. The first picture is showing a baby who is term baby. Baby is pink, crying, tone is normal. And then second, we have a baby who appears limp. Baby doesn't look that pink. There is no breathing efforts. The tone is also poor. So in the case of first baby, we are going to shift the baby to the mother side. We can carry the initial resuscitation like drying, warming, stimulating on the mother's chest. And we can also give skin-to-skin contact and initiate direct breastfeeding. But if the baby doesn't look, if the tone is poor, if the color is blue, and if the breathing efforts are not good, in that case, we are going to shift the baby to the warmer, and we are going to do the initial steps. So what are the initial steps? First, we are going to provide warmth, then dry, stimulate the baby, position the head and neck, and clear secretions if needed. So let us go one by one. First thing is we are going to shift the baby to the warmer. Then we are going to avoid both hypothermia as well as overheating, because both of them can increase the chances of morbidities. We are going to maintain the temperature between 36.5 to 37.5. And we are going to prevent the air currents, maintain the temperature of the room, keep the heater output 100%, and also use warm blankets and linen. Next, we are going to dry the baby. So this is not necessary for preterm babies. At the time of drying, we are also going to do gentle stimulation. We are going to rub the baby on the back, trunk, and extremities. Then position the baby. So positioning, we should avoid both flexion as well as hyperextension. So this is the normal position, sniffing dog position, where we are going to place the baby with slight extension of the neck, and a shoulder roll is placed beneath the shoulders, and eyes should be facing towards the roof. Then we are going to clear the secretions. So we need to remember M before N. So first we are going to clear the mouth, followed by the nose. Do not suction vigorously, and the suction catheter should be placed at a pressure of 80 to 100 mm of mercury. And suction is especially important if baby is not breathing, baby is gasping, there are secretions obstructing the airway, and before initiating positive pressure ventilation, and whenever we find any meconium stained amniotic fluid. So after all these initial steps, we are going to assess the baby. Is the baby breathing now? What is the heart rate? So we are going to count for 6 seconds and multiply by 10. And then we are also going to see how is the color of the baby. So if any of this is abnormal, then we are going to go to the next step, which is initiation of positive pressure ventilation. So positive pressure, now here we have a baby. The baby doesn't appear that pink. Baby is slightly cyanosed. There are no breathing efforts. Baby is apneic. So in this baby, we are going to go to the next step, which is initiation of positive pressure ventilation. So for babies who are born preterm less than 35 weeks, we start with initial oxygen of 21 to 30%. In babies who are term, we can start with 21%. Also, one more important thing to note is all babies at the birth has saturation of only 60 to 65%. This increases at the rate of 5% per every minute. And by the end of 10 minutes, the saturations reach 85 to 95%. So when do we start positive pressure ventilation with bag and mask or neopuff? That is started whenever baby is not breathing or heart rate is below 100. So this is started given with the bag and mask device. All of you might be knowing this. So first is the face mask, which fits on the face. Then we have a reservoir which should be connected to the reservoir end. And also we are going to connect the oxygen inlet to the oxygen source. And also the mask size should be correct. It should be covering the nose as well as the chin. It should neither be too small nor too large. Like you can see, the first one is the correct size. It is fitting on the nose and also it is covering to the chin. The second picture is showing a very small mask. The third picture is showing a very big mask. It is almost covering the entire eyes. And then we are going to hold it with one hand technique, easy clamp technique. The thumb is placed on the upper end. The index finger is placed on the lower end. And with the rest of the 3 fingers, we are going to give a gentle thrust to the jaw to maintain the neck in a slight sniffing dog position. And then we are going to give breathing at the rate of 40 to 60 breaths per minute, because that is the normal respiratory rate for the newborn. So we are going to say loudly, breathe 2, 3, breathe 2, 3. So when we say breathe, we are going to give the positive pressure ventilation with the device. And when we say 2 and 3, the device is going to recoil back. At this time, we are not going to give any positive pressure ventilation. So this has to be given at the rate of 40 to 60 breaths per minute. And then we are going to reassess at every 15 seconds. So the person who is going to give positive pressure ventilation is going to stand at the head end and see the position of the neck and also see the oxygen concentration. Now we have started positive pressure ventilation. The baby is not improving. The heart rate is not improving. There are no breathing efforts. In that case, we are going to follow the next steps, corrective steps, called famously as the MR SOPA. So we are going to do two steps at a time, and then we are going to reassess and see. So the first one, M stands for mask adjustment. So we are going to see if there is any leak from the mask. Is the mask applied on the face correctly or not? Is the size of the mask correct? Next, R stands for reposition the airway. So see if there is any excessive flexion or extension. Place the head back in sniffing position. Again, we are going to give positive pressure ventilation breaths and reassess. Now, if there is no improvement, then we are going to go to the next two steps, which is S stands for suctioning of mouth and nose. So we are going to see if there are any secretions, and then we are going to suction the mouth and nose. And then we are going to open the mouth, then reapply the mask, and again give the positive pressure ventilation breaths. And again, we are going to reassess. If there is no improvement, then we are going to go to the next two steps. P stands for increased pressure. So we are going to increase the pressure slowly to a maximum pressure of 40. So we are going to start at a pressure of 20 to 25 and then increase slowly at the rate of 5 centimeters till 40 centimeters. And last, A stands for air alternative. In that case, we are going to consider intubation. So if baby is not improving in spite of the MR SOPA steps, the next step is intubation. So for intubation is especially done if you are also needing positive pressure ventilation for a prolonged time, or in case of some conditions like diaphragmatic hernia. So we have various sizes of ET tubes and various sizes of catheters based on the gestational age and weight of the baby. So post intubation, again, we are going to give the positive pressure ventilations now through the ET tube and again reassess. At any point of time now, after giving adequate positive pressure ventilation, that is moving the chest. So chest is moving, but still baby is not improving. Baby's heart rate is still low, less than 60. At this point, we need to consider giving chest compressions because the ventilation is adequate. So now we need to start chest compressions. So chest compressions, we give approximately 1/3 of the anterior posterior diameter of the chest needs to be pressed. And we coordinate it with the breaths. So we give one ventilation after every third compression. So there will be a total of 120 events. So we are going to give 90 compressions and 30 breaths. So when we are starting compressions, the person who is doing compressions is going to stand at the head end, and the person who is going to give breaths is going to give it with the ET tube. So we are going to say 1 and 2 and 3 and breath. So when we say 1, 2, 3, we are going to compress. And during the time when we say and, we are going to release the pressure. And when we say breath, we are going to give the PPV breath. So like you can see, there are two persons. The first person, when we say 1, he's compressing and he's releasing. 2, again, he's compressing and he's releasing. So 3, he's again compressing and he's releasing. And then the second person is going to give the breath. So this is done on the lower 1/3 of the sternum, and we need to press at the depth of 1/3 of the chest diameter. Also ensure that we are going to place the pressure correctly on the sternum such that the heart is getting compressed. Do not give it laterally because then the rib cage is going to get compressed and the heart is not going to get compressed. So two-thumb technique is preferred. And when do we stop compressions? We are going to stop compressions whenever heart rate increases more than 60. If the heart rate is more than 60, then we are going to stop compressions and then we are going to continue positive pressure ventilation. So now we have started compressions. We have given it at the almost for 1 minute and still baby is not improving. In that case, the next thing we do is we give medications. So the medication we use is adrenaline, which should be mixed. 1 ml of adrenaline should be mixed with 9 ml of NS. And we are going to take a dose of 0.2 ml per kg. So if a baby is 3 kgs, we are going to give almost 0.6 ml of this prepared solution. So it is better if you can give it through umbilical access, but if that is not available, then we can give it through IV line. But if IV line is also not available, then we can give through ET tube till we secure a line, and ET tube dose is 0.5 to 1 ml per kg. So if the baby is not responding despite all these measures, despite adrenaline, and there is any evidence of blood loss, baby appears pale, there are other features of shock. In that case, we also use a volume expander, which is usually normal saline or ringer lactate. Sometimes we can also use other O negative blood. especially if there is evidence of bleeding. So this we give at a dose of 10 ml per kg. Again, the route preferred is umbilical vein, and if that is not available, we can give through IV line. And the fluid should be given slowly over 5 to 10 minutes, especially in the case of a premature baby. So let us go quickly through the resuscitation chart. So first, after the birth of the baby, we are going to assess three main things. Is the baby a term baby? Is the baby breathing well, crying well? How is the tone of the baby? So if everything is good, baby is a term baby, crying, tone is good, we're going to take the baby to the mother and we're going to provide routine care like warmth, clearing airways, drying, stimulating. But if any of this is no, then we are going to shift the baby to the warmer and we're going to start with thermal care. We'll shift to the warmer, dry stimulate the baby, clear the airway, and then we are going to assess the baby. Now, if the heart rate is still below 100, or if the baby is not breathing, or if there is grasping, in that case, we'll start positive pressure ventilation. But if the heart rate is above 100, baby is not, baby is breathing, but there is labored breathing, in that case, we are going to start on CPAP. So if the heart rate is below 100, baby is gasping, or if there is apnea, we are going to start on positive pressure ventilation. So the initial steps should be done in 30 seconds. And the later, we need to start PPV within first 1 minute. If the heart rate is still below 100, then we are going to do ventilation corrective steps, that is MR SOPA. And if that is also not, if you're not able to, if baby is not improving with MR SOPA, then we are going to intubate the baby. Post-intubation, if the heart rate is still below 60, we are going to start on chest compressions, coordinating with positive pressure ventilation. And if the heart rate is still below 60, we are going to start on medications like adrenaline, NS bolus, or blood. And post the resuscitation, we are going to shift the baby to the NICU for further care. So this completes the NRP program.
Dr.
Thank you,
Arasvi?
Dr. Pranita. Yeah. Thank you, Dr. Pranita. And we don't have any specific questions on newborn resuscitation, but anything specific which we have to take care for a preterm child?
For a preterm child, we need to follow main of a preterm bundle, sir, for maintaining pressure control. We have plastic bags, wraps. When we give oxygen, we need to start on humidify oxygen. And also have a transport incubator ready and shift the baby immediately to the NICU. And always start with CPAP support at birth. The lung fields do not get derecruited.
Dr. Arasvi?
Sir, to please share his thoughts before we finish.
Dr. Arasvi, did you say anything? Hello? Am I audible?
Yes, sir. Please, sir. Please share. Yeah. Yes, sir. Audible, sir.
Yes, yeah. Once again, my special thanks to all the faculty members, Dr. Arasvi, Dr. Aparna, and Dr. Praniti Reddy, for your real excellent presentations, very stimulative and very informative. And I really appreciate the enthusiasm and zeal of you three persons, your passion for spreading the knowledge and skills to the needy personal healthcare professionals like nurses and doctors as well. And amazingly, the attendance is so good. It's above 300 on YouTube. It's very occasionally we see this kind of attendance. It shows our partners, this association of this trained nurses association of Telangana state, their efforts to mobilize the nurses to this useful educational program. And I sincerely, I thoroughly enjoyed the entire session. I was very attentive. Though I had few patients, I requested them to wait for some time. It was a wonderful presentation, and I assure on behalf of PATS, if required, Professor Rajeshwari Garu, we are here to have these kind of programs. We have excellent faculty, experienced, trained, and passionate people to talk on nursing care for newborns, children, and adolescents. I appreciate my
Sure.
special appreciation to Dr. R.S.V. Sri Krishna. Dr. R.S.V. Sri Krishna. Basically, it's an initiative and efforts by Dr. R.S.V. Our body is enriched by the presence of Dr. R.S.V. Sri Krishna. And my regards and appreciation to Dr. Aparna, and as well a new eminent faculty member, Dr. Paranidhi Reddy is coming up. We wish her all the very best. You will be there
Pranita Reddy,
with us
sir.
in all our academic activities. So, thank you, Dr. Professor
Pranita,
Rajeshwari Garu.
Pranita Reddy.
Yeah, I'm sorry. I'm Reddy. I'm sorry. Thank you, Dr.
Yeah,
Pranita
thank you,
Reddy.
sir.
You will be part of us, and thank you. Thank you, one and all. Thank you.
Yeah, thank you, sir.
Over to
Thank
you.
you. Thank you, sir. It was really good. 3 sessions. 3 of you done a great job. It's really good. And like, sir, Sri Krishna, sir, if you can say when will be the next session, that will be great. And sir, I just wanted to say here, sir, most of the students have joined in the classroom screens, big screens. So that is the reason here you are in YouTube only 300 it is showing, but almost all students in the colleges they have kept in the classrooms. Only 2-3 photos I shared to Sri Krishna sir, but most of them kept in the group, like they have joined in the classrooms. And
Thank you.
whenever
Thank
we
you,
need,
Rajeshwari ma'am.
Thank you.
yeah, and
Yeah.
whenever we need, we will be taking help from you people like this.
Thank you. Thank you,
sir.
ma'am. We know
Yeah.
healthcare, we can't do it alone. And nurses are the
Yes, sir.
backbone, especially of newborn care.
Yeah.
It's called a nursery,
Yeah.
rightly. And nurses
Yeah.
have a very important role. And I know that at the level of JNM and probably when you're teaching general nursing, newborn care does not get covered as much as it deserves to be. And I'm sure these sessions will be very helpful for the young nurses to understand newborn care much better. And on behalf of PATS, I'm very thankful to our president, sir, who spared his time and actually heard the entire session. Thank you, sir. And also for giving us this liberty and freedom to associate with other organizations and take up webinars of this scale. Overall, we've been able to reach out to more than apparently 2,500 nurses minimum in this session. And ma'am, we'll have the next session on Friday. I think that comes on the 9th of May. So the next session will be on pediatric critical care. Dr. Sunkoj Bhaskar sir has been the chairperson of the pediatric critical care chapter of IAP Telangana state, and he has seen how critical care has come up to a wonderful level where we have truly national level and even world class speakers with us. And the next session will have good participation of eminent faculty teaching the very basics of critical care and emergencies to the nurses of TNAI. Many thanks to you, ma'am, for enabling this session. And we'll continue this effort. And it's been a very fruitful 2 hours. Thank you for this opportunity. And we'll meet you all again at 3 o'clock next Friday on the 9th of May. Thank you.
Thank you. Thank you.
Thank you.